think Barry was asking about hypersomnia in situations like for patients with comorbidities. Barry, did you feel we sort of touched on that with the last section?
Well, I mean, the idea was, you know, I have patients on various hypertension medications, diabetic, and other comorbidity medications, and you know, they come in sometimes with a long list on a loose leaf paper, you know, 25 different medications. The reason I asked this question is I may not be familiar with medications they're taking for other comorbidities, whatever they may be, including, you know, headache medication or other medications that are affecting their sleep, you know, and I'm making the assumption, oh, if I can treat your OSA with whether it's oral appliance therapy, whatever other therapy, you know, that I'm going to improve your daytime sleepiness. And then, you know, the patient comes back and doc, I'm still tired. And am I missing something in their very common hypertension, diabetic, and other comorbid medications, maybe for stroke or, you know, that is influencing their daytime sleepiness that I may not be aware of, you know, as Dennis, you know, we can tend to be hyper focused on the OSA and, you know, not really looking at their total medication profile. So I kind of throw that out to the pharmacist.
Very practical question, very practical, because I think all of us deal with hypersomnia and complaints of sleepiness. And maybe some direction from the pharmacists here. Are there medications that are fairly commonly used that we should be having our antennas up that, hey, maybe your sleepiness is because of, let's say, you know, some Benadryl in your over-the-counter thing, or some other medications that are usually commonly associated with sleepiness? Vito, you want to take that?
Well, you know, like when it comes to hypertension, you know, many of the common drugs used can cause sleep disorders. You know, they can keep you awake, or, you know, especially like alpha blockers or beta blockers, they will affect your sleep, you know, and they have to be either adjusted to be taken at a certain time of the day, or maybe try a different product if the patient is eligible for. Like, you know, a safer bet would be like a calcium channel blocker, you know, that will lower your blood pressure without, you know, affecting your sleep much. You know, also there's certain, you know, steroids, you know, people that are on steroids, you know, that will, you know, make you have difficulty with sleeping as well. So, you know, we usually recommend that you take your steroids, you know, in one dose, usually in the morning is best, to avoid that stimulation from the adrenal gland. And the same thing with SSIRs, you know, people that are on that, you know, I mean, initially they make you sleepy, but then as you keep taking them as well, you know, they will cause stimulation after, you know, you take them for a month or two. Many people have a harder time to sleeping. So their dose should probably be adjusted, you know, as they've been on them for, you know, a longer period of time.
Give me some common brand names that I would look out for that would alert me that these medications may cause some daytime sleepiness.
Well, let's say with the alpha blockers, you know, tamsulosin can definitely cause a problem. Most people switch to finasteride because it has a better tolerance to sleep. When it comes to beta blockers, atenolol and metoprolol, you know, they're usually very hard on sleeping. So many doctors do switch to calcium channel blockers when it comes to that. That's like nifedipine or verapamil, diltiazem. You know, they have a better profile for sleep. And the steroids and the SSIRs, you know, they all have the same profile. So.
Sounds good. All right. Well, thanks for that.